Segun's a consultant in intensive care and ECMO at Barts. He's got many accolades and many achievements, all of which speak highly of his achievements, and he's a well-known author and an editor for the Intensive Care Society Journal, and he writes for The Bottom Line, and he's at the forefront of a lot of work that's been done for both ECMO, echocardiography and POCUS. So once we get the technical issues sorted out, we'll make a go of the presentation, and I'll pass it over to Segun.
All right, thanks for the intro. I'm going to talk about echo and mechanical support. This, in my opinion, is true critical care echo, and is probably the area that anybody who is a practitioner in intensive care and interested in advanced echocardiography should really try and take hold of and own. Because at the moment, cardiologists aren't really doing this and physiologists aren't really doing this. So we should really embrace this as kind of our thing and start doing this more and more. And this is very clear if you look at internationally, lots of echo guidelines. The ESC have just written a big guideline on echo and mechanical support that's driven by Hatem's Abu Mari, who's a consultant at Harefield, and he's called very much for intensivists to do it. The EDEC have embraced this, and the Australians have embraced this more and more, and that's part of the DDU. However, I'm going to expand on this. So most of you guys should know Matthias Dorka. He is an absolute POCUS legend who works in Surrey, and he says this all the time, a single organ scan is an incomplete scan. So I'm actually going to talk about POCUS and mechanical support, not just echocardiography, although it's going to have a heavy focus on advanced echocardiography. Here are my declarations of interest. My big one relevant to the presentation is that I teach for the EDEC, and I'm part of the EDEC examining committee. I'm part of the BSc Level 2 ACCE examining committee. So there will be questions in mechanical support in ACCE going from now on. I was part of the FUSIC committee, so I've got a big vested interest in kind of echo mechanical support and cardiogenic shock, as I think that should be part of FUSIC. I'm also part of something called Genius, which is General Intensive Care Ultrasound for the ESICM. And they also have kind of a fledgling bit on mechanical support, but really that's kind of their gateway to EDEC. And I have lots of huge cognitive conflicts of interest in this, in that I work in a cardiogenic shock centre where we have access to mechanical support, and I sit next door to Alistair Proudfoot, who wrote the UK guidelines called Shocks to Survival on essentially cardiogenic shock. So I have lots of conflicts of interest around this, and I'm interested in it. This is an interactive presentation, so please at any point, if anybody has any questions or interests, or any questions or comments, just raise your hands or shout out. So what I'm hoping to cover over the next 45 minutes to an hour or so is the utility of echo and shock, the questions that we want to answer with imaging, and some of the indications for echocardiography, mechanical support, and a little bit about the magic word weaning or liberation from mechanical support. So why is this important? So really when we're talking about mechanical support, you're really talking about cardiogenic shock assist. And cardiogenic shock is basically a low cardiac output state plus systemic badness. So having a low cardiac output by itself is not a problem, because there are loads of people that walk around with cardiac indices that are quite low, but they're perfectly fine because their myocardial oxygen demand and supply is balanced, even though they have a dilated cardiomyopathy and ejection fraction of 15%. Problems come when your oxygen demand supply becomes out of balance, and then you have a low cardiac output state plus the associated badness of poor organ perfusion. So cerebral hypoperfusion, organ congestion, systemic hypoperfusion with things like raised lactate, mottling, etc., etc. And I've mentioned here it can be acute versus chronic. It can be ischemic or non-ischemic. And our conventional treatments, unfortunately, aren't very efficient, in that basically what we have is so you can treat the underlying cause with whatever you have. So you can stent a lesion, which is probably the most effective treatment that we have for cardiogenic shock. You can give filling to try and restore perfusion, and you can use inotropes to try and restore perfusion. And our conventional treatments, aside from mechanical support, all have problems in that they all basically improve myocardial oxygen supply at the expense of myocardial oxygen demand, which is why we like the idea of mechanical support devices, because they essentially will improve myocardial oxygen supply without necessarily making the heart work less. And here's this slide basically illustrates that point a little bit better. So inotropes by themselves, whilst we think inotropes are great and fantastic, they basically, you flog the heart to make it produce more oxygen. So they increase myocardial oxygen demand, they can be arrhythmogenic, and there is currently no data at all to suggest that one inotrope is better than another, despite what you might hear from every intensivist who has their favorite inotrope that they keep in their pockets, you know, that as their lucky socks. All of the papers, every single paper published up to date, show no benefit of one single inotrope over another. And the most recent one is something called DOREMI, which looked at dobutamine versus norenone in cardiogenic shock, and showed absolutely no difference whatsoever. DOREMI 2 is coming up soon, which is going to be dobutamine versus noradrenaline versus placebo, which is going to be really, really interesting, because if it shows that there's no difference compared to placebo, then I think we're in real trouble. But nonetheless, that there's something to think about. So yes, back to cardiogenic shock. So it's low cardiac output state plus badness, and we have ways to try and quantify how bad your cardiogenic shock is. And the most recent and most widely spread of this is what's called the SCAI classification. SCAI stands for the Society of Cardiovascular Angiography and Intervention, the American group, and they have the SCAI classification, which goes from A to E. And it's designed this way because first of all, it gives you a nice, easy to remember mnemonic. So A is at risk, B is beginning, C is classical, D is deteriorating, and E is extremist. So as you go up from A to E, your outcomes get worse. But it also shows it's actually linearly correlates. So when they actually classify these patients using latent regression analysis, it actually showed that your mortality linearly goes up as you go from SCAI A to E. So SCAI E has a mortality of about 40–50%. And in terms of SCAI classification, apologies, the slide came out a little bit blurry. So at risk is basically you have a lesion, but otherwise you're all right. So you have a lesion that will suspect, so you've had an MI, you've got a low cardiac output state from myocarditis, whatsoever, but everything's okay. B is beginning, so you're starting to see some early signs, so usually tachycardia and maybe a little bit of hypotension, but you still have preserved organ perfusion. C is classical, and this is where you start to see your true cardiogenic shock. This is what we're used to. So you've got people who are cold, they're mottled, they have a raised lactate, they're hypotensive, that's refractory to fluid, that's refractory to fluid loading, and they're starting to get things like signs of either left-sided or right-sided congestion. D is they're getting worse, or what we used to call sliding on inotropes. So you need to be on at least one. You need to be at least once you're on more than one inopressor, you're by definition SCAI D, and E is basically you're dying and you're in cardiac arrest, and we need to do something about it. So this is our little Barts algorithm of what we do. So at Barts, we are basically trying to model what we think cardiogenic shock should look like for the rest of the country. And so if you have a new score of more than 5, you basically instantly score the need to have an echo. Once we identify or we start to think cardiogenic shock, you need to try and risk stratify and classify the patients. And SCAI C, D, or E pretty much gets you escalated to an ICU consultant. And as mentioned, Alistair wrote this amazing document called Shock to Survival, which is basically kind of the model for UK cardiogenic shock. And it's trying to turn cardiogenic shock into the new trauma, where we basically have hub and spoke models, and the focus really is on early recognition. We're basically trying to get probes on people who are shocked or hypoperfused to identify whether it's a cardiogenic component. We're trying to recognize that, get appropriate evidence-based treatments, transfer to appropriate centers where the evidence-based treatments can be given, and escalating to appropriate support and mechanical support as necessary. So how does ECHO fit into all this? So this is an old document now, the 2014 ESICM guidelines on consensus on monitoring in circulatory shock. And there they made a very strong recommendation for the use of echocardiography as the initial modality to evaluate the type of shock. And that's pretty much because echo can tell you a huge amount of information. They have literally 2 weeks ago revised this. It's still not published. It should be published very soon. But again, they have upgraded. They've basically had another roundtable assessment, and they have upgraded their recommendations. And echo is now super strongly recommended as a first-line tool to evaluate the type of shock. So really, it's right up there as one of the first tools that you can have. It can evaluate a whole bunch of stuff. So it can give you a diagnosis. So if the papillary muscle is hanging off, or they've made a big hole in their ventricle because of their MI, it'll tell you that. It gives you cardiac output, and you have to remember that cardiac output and cardiac index is how you actually classify cardiogenic shock. So most people classify cardiogenic shock as a cardiac index of less than 2.1 mils per minute per meter squared. So that's actually really, really important. So whilst the patient may be shocked, if you think the patient's got cardiogenic shock, and you put the probe on, you've got a hyperdynamic heart with a cardiac index of 5, they've not got cardiogenic shock, they've got a different form of shock. They need to look for something else. Gives you information about left atrial pressure and right atrial pressure. It allows you to assess systemic and pulmonary vascular resistance, and it can allow you to assess fluid responsiveness with a few patients that may or may not be in a state where preload may be a temporizing measure that you can use to get them through this period. And then when you're going into and when you're going to MCS, it then gives you a whole bunch of information about the chambers, which I'm going to talk about, appropriate positioning, what type of device to use is really, really important. Allows you to assess for complications of insertion. And then I'm going to talk about right ventricular function, because RV function is actually a very, very important part of mechanical support and is a key component in determining whether you survive your acute cardiogenic shock or not. So you have to remember that shock comes in different flavors: distributive, obstructive, cardiogenic, and hypovolemic, with neurogenic as basically a subset of distributive, and dissociative shock being where your mitochondria fail, and basically you've got things like you can have cyanide poisoning or something like that. That means that you basically can't, your mitochondria don't work. So you have to remember that getting a diagnosis is absolutely, absolutely crucial. And echo is one of the few tools at the bedside that can pretty much instantly give you a diagnosis, especially for obstructive shock. So you will see fluid around the heart, or you'll see a big right ventricle instantaneously, and that helps direct your treatment. So once you've identified that you think you've got pump failure, so left ventricular, right ventricular, both failure as the main thing, the next steps that echo allows you to do is this concept of hemodynamic stratification. And hemodynamic stratification is becoming increasingly important. Hopefully, those of you guys online who are intensivists would have paid attention and realized that quote unquote landmark trial was published 2 weeks ago called Andromeda Shock 2, which basically looked at hemodynamic profiling and septic shock and showed a mortality benefit. This is questionable, but one of the big things that they did as part of the hemodynamic profiling was they used echo. So echo allows you to substratify your pump failure into different phenotypes. And when you're talking about cardiogenic shock, there is something called the Diamond-Forrester classification, which classifies you into these 4 phenotypes based on your peripheral perfusion and whether you've got signs of congestion or not. And so you can be warm and dry, warm and wet, cold and dry, and cold and wet. Warm and dry is good, cold and wet is bad. And based on your echo, your circulatory status, your systemic vascular resistance, you can work out what you are. And the reason why this hemodynamic phenotyping is important is because the treatments are different for different phenotypes. So if you're warm and dry, but you have signs of hypoperfusion, it may be that fluid is an appropriate first-line treatment. And you might see this in people with right ventricular infarction in particular, because in the short term, the RV acts like when the RV gets stunned, it acts a bit like a passive conduit. So a little bit of fluid might just give the RV the perfusion it needs until you get them stented, and they can get through their first 12 hours of a bit of stunning, and the RV starts working again. But that might be all they need. Whereas once you start getting congestion, you need to start thinking about ways to decongest. So you need to think about diuresis. And when people get cold, it means that their cardiac output or their peripheral perfusion is impaired. So then you need to think about inotropes. I hope this all makes sense so far. If anybody has any questions, please feel free to interrupt. And just to mention the importance of echo in this, so echo allows you to actually do a hemodynamic and echocardiographic Diamond-Forrester classification. And this is all stuff that we know because you guys have been talking about this all year. So using your left-sided filling pressures, so your E and your E over E prime allows you to work out whether your LVEDP is elevated and whether or not you've got pulmonary congestion. Using your TRV max and Vexus allows you to assess whether you've got right-sided congestion. So that way you can fine-tune your hemodynamic classification. Let's not forget that you can use lung ultrasound as well, and lung ultrasound for pulmonary edema actually has lung ultrasound for B lines actually has a pretty decent sensitivity and specificity for picking up an elevated LVEDP. So don't forget that, and especially when you've got weird patients who are indeterminate on your left atrial pressure assessment, so they've got mitral annular calcification or mitral valve disease or something weird like that. That means you can't use E over E prime. Just having B lines everywhere and big pleural effusions can be enough to tell you that they've got an elevated wedge pressure, and therefore they're wet. So once you've identified cardiogenic shock, you've got your 3 musketeers or your stone, paper, scissors that you can use for managing these patients. You either use an inotrope or actually inopressors, fluids, mechanical support, or nothing. A very, very important thing to understand about echo, hopefully we've been drumming that into you over the year, but particularly echo in these really, really sick patients in echo mechanical support is the importance of context. So here is one patient, and you can look at their echo, and you can see that their heart doesn't look particularly fantastic. And here is the same patient. Oh, well, here's what looks like a different echo, but this different echo is actually the same patient. It's the same patient, and this is before and after. So the previous picture is where the echo looks worse, and now the echo might look here. The echo actually looks better, but here the cardiac output's actually worse. And the difference is the other picture I showed you is the patient after we resuscitated and started some inopressors. And so what we actually did there was we unmasked their LV dysfunction by giving them fluids and restoring their afterload. So whilst you might look and think that this echo here is actually pumping better than this one here actually has the better cardiac output. And so hence why whenever you're reporting critical care echoes, we emphasize the importance of including your loading conditions. So you need to write down what ventilatory settings there are, what their map is, what their, if you've got SVR, what their SVR is, and take all of those things and write down the drug that they're on, because all those things will affect what your echo looks like. Okay, so now we're talking about mechanical support. So you need to think about how quickly you need to do it, what you need to support, what your access options are, and in particular, if you're looking at mechanical support for cardiogenic shock, you need to think about the lungs, because if the lungs are bad and the heart's bad, your strategies are going to change very slightly. So what have we got at Barts? So Barts, we have balloons, we do VA ECMO, we have percutaneous right ventricular assist devices or percutaneous RVADs. We have a percutaneous LVAD or microaxial flow pump, and that's basically the impeller. And then we can do central ECMO in some for post-cardiotomy. So how are you going to pick what device you're going to use? So you need to look at the left heart, you need to look at the right heart. And then you need to, so before you think about mechanical support, you actually need a fairly comprehensive echo, because you think about left heart, right heart, and valves. So based on their LV function, if their LV is down, then they're going to need left-sided support. If their RV is down, they're going to need right-sided support. If both are down, they'll need biventricular support. If the right side is down by itself, you might get away with univentricular support, but for the right side. Valvular dysfunction becomes really, really important, because if they've got particularly aortic valve incompetence, so they've got aortic incompetence or aortic dissection, that pretty much rules out all forms of percutaneous left-sided support. And then you're looking at either central ECMO or basically surgery to fix the valve and then put them on central ECMO. And then you also need to think about whether or not they've got any intra-atrial communications, because that, again, might A, give you a diagnosis, but B, also change your strategy for support. So this little slide here just gives you an idea of what we think about when you're tailoring support. So you can do unilateral support for the right side in patients with individual right-sided pump failure. But most of the time, and then also that depends on speed, because right-sided supports can be quite tricky to put in. Then you have lots of univentricular options for left-sided support, with VA ECMO basically being kind of like your Bezoar, or like your basically your Swiss Army knife that just covers everything. So VA ECMO is kind of your go-to. It'll give you biventricular support, but at a cost. So I'll kind of go through these options one by one. So I'll start with the left heart. So our left heart percutaneous options, really, we've got balloon pumps. I'm going to include balloon pump here because for most people, this is still the most common form of mechanical support that you have in your institution. However, a lot of us will argue that the balloon pump is not really mechanical support, because what it actually gives you in terms of augmentation of your stroke volume is relatively minimal. We've got the new kid on the block. Well, not really the new kid on the block anymore, but for many people, maybe it's the incoming kid, widespread kid on the block, and that's the impeller or microaxial or a left ventricular microaxial flow pump, to give its proper name. Tandem hearts are weird. I've never seen one. I think there's a couple of places in the States that like them, but I've never ever seen one. And then we've got VA ECMO. So I'll start with the balloon. So hopefully most people here have seen a balloon pump. Yes, no? Actually, you may not have, because you're actually using these less and less and less, and that is because the evidence base for them is not fantastic. But if you do any ICU exams, you expect to know about them in the ICU exams, and they really like this in the FICM for some strange reason. Even though they're not really using them. So the concept is simple. It's balloon counterpulsation. So you stick a big helium balloon into the descending aorta, and it deflates in systole and inflates in diastole. And as it deflates in systole, it sucks blood out the LV, and as it inflates in diastole, it pushes blood back up the LV, back up the aorta, and perfuses the coronaries. They put it infemorally, so that's where we usually put them in, but you can put them in axillary, and you can't put them in retrograde, so the surgeon can put them in intraoperatively. Aortic regurgitation is pretty much a no-no. Aortic dissection is usually a no-no, although some people can let the true lumen in some cases after the operation. And so it's supposed to work as a ventricular assist device by, with the suction and pushing mechanism that I've mentioned, but it's not a particularly fantastic device. And also, if you look, so there was in a post AMI cardiogenic shock, there was a big trial called IBP Shock 2 that showed no mortality benefit from using a balloon pump. And that's the reason why balloon pumps are slowly being phased out. This waveform you'll need to know about if you do the FICM exams. I won't talk too much about it because we're not really doing a balloon pump teaching session. But basically, that's how it works. It basically augments your diastolic pressure and augments your systolic pressure. So increase your diastolic pressure and reduce your systolic pressure. So the idea here is it improves perfusion and makes your heart work less. Sadly, this is supposed to be video, so I'm really sorry they're not playing. So this is balloon pump positioning, and this is using TOE. So what you want to do is you want to get your balloon pump tip in the descending aorta and make sure that it's below the origin of the subclavian artery. And you can do this either with transthoracic or transesophageal echo. On transesophageal echo, it's very, very easy because you basically see the aorta as this big round circle, this big long tube. Put the probe down, turn it over to the left, and there you go. And then you need to pull it back until you see the first bit. As you come up the descending aorta, you pull it back until you see the first kind of knobby bit come off the descending aorta, and that's your left subclavian artery. And as long as the balloon pump is down there, everything's fine. On transthoracic, you need to use a suprasternal view. So that really tricky view that lots of us don't get, where you stick the probe on the sternal arch. You get a nice, you basically get the aorta looking like an upside down U, and your left subclavian will be kind of one of the little bits that comes off the top, and then you can use that to guide your people when they're putting balloon pump in. Balloons are great. You need to be careful of patients that look like this. So this is somebody with a septal knuckle, and hopefully you guys can all see here where my mouse is. You can see that they've got systolic anterior motion of the mitral valve, and as a result, dynamic LVOT obstruction. And balloon pumps don't like this because they make it worse. Because all they'll do is they'll just create that Bernoulli effect and basically suck blood through the heart, and therefore, as long as the balloon pump is there and you've got dynamic LVOT obstruction, it'll make the patient worse, and they'll get really, really sick really, really quickly, and you'll notice it because the lactate will basically double in about 3 hours. So yeah, this patient was a patient on ECMO with the balloon pump in, and we took the balloon pump out, and they got better. I'm going to spend a little bit of time talking about impellers. I think these are important to talk about. Many of you may not have seen them, but these are coming. Partly because currently, thanks to this trial called Danger Shock that was published 2 years ago now, impellers are the only mechanical support device in cardiogenic shock that have been associated with a mortality benefit. But also, there has just been a submission to NICE, the National Institute of Health and Clinical Excellence, for the use of microaxial fluid pump devices in cardiogenic shock, and NICE have provisionally approved them. If NICE have provisionally approved them, then it means that people are going to start using these devices. So within the next couple of years, especially if money is attached to them, you will start seeing impellers everywhere. So, and what will happen is the cardiologist will put these in. They will send these really sick patients up to ICU, and if we don't know how to image them, we'll basically end up holding the baby. So you will need to know about impellers. I personally think. At the moment, because there's no money for them, we're not really putting many in unless you work in Harefield, in which case, apparently half the cardiogenic shock units got impellers in. But I really think that these are coming now. So what is an impeller? So basically, it's a very, really tiny impeller, as in IMPELLER, that sits in the left ventricle and whizzes around and basically sucks blood out of the left ventricle and then ejects it through the aorta. And that's how you put them in. So you usually put them in femorally, or there's different types actually. The CP is the one that goes in femorally, and it sits in the LV like that. And what will happen is it whirs around and it sucks blood into the inflow, and the blood gets ejected through the outflow, which is at the top here in the aorta. That's how they work. So when you've got it nicely positioned, the inflow cannula sits nicely in the LV, and the outflow cannula sits in the aortic valve, and it sucks blood out through it. But it's very, very important because there's loads of delicate valvular apparatus around where the impeller goes in. You need to have a really, really close look at the mitral valve every time you look at it, and because they can basically give you acute mitral stenosis and acute mitral regurgitation by either obstructing the mitral valve or by getting tangled in the apparatus. So impellers and echo basically go together hand in glove. There's this monitor screen that they sell to you, and they say, oh yeah, just look at the monitor screen, it'll tell you everything that you need to know. This all comes from the States, where their there are lots of places in the States that don't have a lot of access to echo, and critical care echo in the States, is, believe it or not, it's actually still in its infancy, and loads of people don't do it. So they have designed their impeller for lots of people who don't do echo and don't have immediate access to echo. What I will tell you now is that if you're going to have an impeller on your unit, you need to have instant access to echo, because there's one thing that these devices do: they move. There's a little diagram of what they do. So basically the suction, by sucking blood through the from the inlet, they drop your left ventricular end diastolic pressure and your left atrial pressure, and therefore basically reduce your myocardial work. And by injecting blood through the outflow, they basically improve your systemic perfusion. So exactly what you want a device to do: reduce myocardial oxygen demand, increase myocardial oxygen supply. There are three main types at the moment that Biomeds, which is a subsidiary of Johnson & Johnson, sell, and they're the CP, the 5.5, and the RP. The CP is the one that you'll mostly see, and this is one that's put in femorally. So it's, be careful. Don't let your cardiologist think about this as a balloon pump light, or like a balloon pump with knobs on, because it's not quite. It's a much bigger device. It's a much more tricky device. Goes into the femoral artery, sits in the LV, and it will give you about 4 liters of flow. If you can look, it's a pretty decent size introduced. So it's a 14 French. You're sticking a 14 French pipe into a femoral artery in somebody who's probably got a degree of ischemic heart disease. So limb perfusion problems are not uncommon. Then there's the 5.5, which is placed axillary. This is a massive device. So you stick it in axillary or stick it in centrally. So you need a surgeon to put that in for you. And these are quite nice because they basically, you can have these and the patient's going to be awake and they can walk around, and they basically work like a mini LVAD. They often put them on as like a what's called, like they put a side graft on the axillary artery, and it can work really quite nicely. And there's this really nice concept of what we call ECMO plus impeller 2.0 or ECpeller 2.0 that's worth reading about. That's really, really quite nice, involving using a side graft and sticking these things in. And last but not least, there's the RP, which is basically an impeller for the right heart. And it's basically, it goes into the, so the inlets in the RV and the outlets in the pulmonary artery, and it sucks blood out the RV and shoves it in the pulmonary artery. I've never seen one of these. We use a different right ventricular support device called the Protect Duo at Barts. However, there's some places that quite like this. So my friend Jeff works in Miami Transplant. So he has like a huge 180 bedded ICU and with loads of cardiogenic shock, and he sticks in a fair few of these, and he says they're quite nice. And that's what they look like. So the 5.5 is big and chunky. The RP has a funny shape to get it into the RV and the PA, and the CP is one on the right. Okay, just be careful about positioning. So positioning is why echo is really, really, really important. Because as I've mentioned, these things, because they're not anchored in the ventricle, they need to float through the ventricle, and that means they can float around and they move in and they move out. So you need to know what they look like, what appropriate position looks like, and you need to be aware that these things can move around all the time. So appropriate positioning should be that the pigtail sits in the ventricle, and this little black line, which is basically where the outlet is, the black line that should be at the level of the annulus, and the outlet should be up beyond the aortic valve. And you can kind of see these on your echo. So on your echo, if you look closely, you can see the inlet, and the inlet should always be about 3.5 centimeters below the aortic valve. And you can check the outlets and make sure that the outlet, you'll see some color, you basically see some flow acceleration, and the outlet should be above the aortic valve and in the ascending aorta. The other thing that's really, really important is the device actually has a natural curvature on it, and what that curvature should be kind of towards the septum. So it should make a J going towards the septum. So a bit like this. So this is a well-placed impeller. So here is your inlet down here. Here's your pigtail, and the outlet should be up here. So this looks kind of nice. It's kind of curling the proper way. And then when you do your measurements, so that inlet is just about 3.5 centimeters below the aortic valve, and that's exactly where we want it to be. And this is what it looks like on TOE. So here the inlet's down here, and then I've just put some color up here at the on the outflow, so you can actually see that there's the turbulent flow of the outflow, and you can see this. So this is a nice position impeller. It's curling appropriately. It's curling towards the septum. If it curls the other way, that actually causes problems as well. So you don't want that to happen. And then the outflow is doing exactly what it's supposed to do. So hopefully you guys can see that this is bad positioning. This is way too far in, and this is actually abutting the inspiroseptal wall. So yeah, here, and then what you end up with here is you end up with lots of suction alarms because the device won't work, and it'll basically be suctioning against the LV wall, and then you'll get lots of alarms, and basically the device, the output from the pump will drop. And you can also see the same thing here in this poorly positioned impeller. You can see that the outflow is now down below the aortic valve. This is too far and it needs to be pulled back. The device has basically like a little screw at the bottom, so you can kind of adjust it, and your cardiologist can come along. It's basically a bit like a PA catheter. It's got like a big sheath thing, and they can come along and they can unscrew it, and they can move it forward and pull it back. The one thing you can't do with an impeller, so if the impeller goes out beyond the aortic valve, you can't safely reinsert it. So you basically have to go back to the cath lab and reinsert it for me. Okay, so now we're going to talk about peripheral VA ECMO, which lots of people are here for, and they think it's the meat of the discussion. But remember that it's mechanical support device is more than ECMO. So some of you guys might have seen this. You have to read about this for exams, etc., etc. But PVA ECMO is basically about taking a big pipe and sticking it into the right atrium and sucking all your blood out your right side, sticking it through a pump and an oxygenator, and then shoving that blood back in through your left side. And if you're using peripheral VA ECMO, that will go either through your femoral artery or auxiliary artery, usually your femoral artery because it's the easiest one to get, and it shoves a whole bunch of blood, and it can give you anywhere between 4 to 6 liters of flow, or with some modification go even higher than that. And we'll shove all that blood into the ascending aorta and back in a retrograde fashion towards your heart. So it's basically modified cardiopulmonary bypass. So this is what your pump and oxygenator looks like. So blue blood comes to the patient, goes into the pump, goes through your oxygenator where basically it's then that blood is now oxygenated, and then the red blood goes back to the patient. So echo and ECMO. You need to identify your diagnosis, and in particular, you're looking for reversible causes. So ECMO is not necessarily always reversible causes, because maybe they've got a non-reversible cause, but that's if you're bridging somebody to transplant. Because with ECMO, you always need an out, because you can't basically live on ECMO. After about 2-3 weeks, bad things start to happen to you. If you're on VA ECMO, your ventricles start to clot and bad stuff starts to happen. So you need some kind of hemodynamic instability that has an out. Your echo will also look for your contraindication, so aortic dissection, regurgitation, peripheral artery disease, peripheral vascular disease. That means you can't put your pipes in. And for VV ECMO, so I'm going to talk a little bit about VV ECMO, even though VV ECMO is technically not mechanical support because it kind of comes under ARDS, but it kind of is, because VV ECMO is actually really, really good for supporting your right ventricle. Because when you drain the blood out of the right ventricle, and you see this with all these guys who turn up with that really, really bad ARDS, their right ventricles balloon out, and you stick them on VV and it just shrinks, and their anapressors just disappear. Because you've just reduced all of that. You've just dropped their PVR, reduced the amount of work that the right heart has to do, and everything just gets better. The LFTs that get better, their congestion gets better, and the renal failure goes away because you stop all of the venous congestion that you just caused by destroying the right ventricle. So for VV ECMO, you need to think about your out. So even for VV ECMO, I still think anytime I go to retrieve somebody or assess somebody for VV ECMO, I do a quick echo because I'm really interested in this. But because you have all of this stuff going on, the choice of modality is not always straightforward. And this is especially true when people have got ARDS. It was one of the other reasons why I need to think beyond the heart, not to think about echo. Because remember, the new definition of ARDS that came about 2 years ago now includes lung ultrasound. So you have to remember that you can assess these patients, you can diagnose ARDS now using lung ultrasound and your PF ratio. So therefore, being able to assess for B-lines in the context of either pulmonary edema or ARDS and consolidation becomes really, really important when you're assessing these patients, because you may get a call to assess somebody for potentially VV ECMO or VA ECMO, and then you might have a look at their lungs and find that their lungs are a problem as well, and that is going to change your strategy. Or you come to assess somebody for VV ECMO and look at their heart and you think that their heart's terrible. So your strategy then changes, and you need to think about what we call hybrid configurations, which I'll come on to a little bit later. Let's not forget, this might be useful as well. So this is a nice lung point. So you might get called to put somebody in ECMO and they've just got a pneumothorax and he's draining. Okay, so I'm going to talk a little bit about cannulation as well, because remember, this is POCUS in mechanical support. So if you find somebody, if you've got sick patients, you've identified that they need to have some form of mechanical support, you need to think about your configuration, and then you need to think about your ultrasound guidance. And your ultrasound guidance for your access is absolutely crucial. You need to get it right first time, not backwall the vessel, not cause a big hematoma. And what most people do, so it's all Seldinger. So you get a needle into the vessel, you stick a wire in, and then you do some kind of sequential dilatation over that wire to get your massive pipes in. Because remember, you're going to, for VA ECMO, you're generally looking at, in particular, your drainage cannula is probably the most important one, which is the venous cannula, because that determines how much flow you're going to get. And so you really want a nice big, decent drainage cannula. So most adults will use a 25 French. Some people use 27s or 29s, and that's a massive pipe. So you want to make sure that all goes nice and smoothly. You dilate nice and smoothly, and then after you've got everything in your echo, then it's going to then become important to confirm the appropriate position of your cannula and see if there's any complications after you started your ECMO support. So as I've emphasized again, your access is absolutely crucial, and you need to make sure that you get this right. So for people who aren't doing this, this is super, super important. So all arterial, all access in my mind should be done in this way. And this is the tracking the dot, or basically tracking your needle. You can do it out of plane like this or in plane, but whichever way you do it, you need to track the dot of your cannula or the dot of your device. Because if you cannot, so hopefully here you can see that there's this dot, and he's actually putting the dot towards the artery. He's just doing a peripheral arterial line. He's now punctured the artery, and then after he's punctured the artery, he's going to make sure that that dot stays in the center of the vessel. Listen, this is the proper way to do it. So the way that because we're used to doing IJs, and people are a bit sick, and so the IJ is fairly forgiving, and it can do what we call the magic trick, where you basically just shove a needle. You basically stick your probe on, say a big circle, shove your needle towards the big circle, and pull back, and then until you get blood. That's not ultrasound guidance. You need to do this: track your needle the whole time. If you're in a pinch, you've got a small vessel or things look tricky, this can be your best friend. It's something called a micropuncture device, or micropuncture needle, and it's a tiny 21 gauge needle with a tiny wire, and over that you can put a little micropuncture sheath and dilator, and through that you can basically stick a bigger guide wire through which you can stick something over. And if you're struggling, micropuncture needles can be your absolute best friend. And there are lots of people I know who do micropuncture as part of their standard procedure whenever they're doing any form of vascular access, so central lines, etc., etc. So Barts, when we put people on ECMO, we use what are called sheaths, a bit like a pulmonary artery catheter sheath, or like what you see cardiologists use when they're doing angiography. So they put a little sheath into their artery, and then they put all their stuff through that. So we do vascular access sheaths, stiff wires. So remember, there's different types of wires: floppy wires and stiff wires. Your standard central line wires and floppy wire. Because we're putting these big long pipes, they need to go straight up into the heart. We use stiff wires, which is very similar to what the cardiologists use for angiography. So we use these stiff wires because they're gonna kink less, and they allow you to basically shove stuff over them. And then after you've dilated, you're gonna put your pipes into the right place. So there's our standard sheath. This is what it looks like. We normally use 7 French ones. These are 6 French. We have a series of dilators. I'll go over them. And then over those dilators, we then put a cannula. And the cannula come in different sizes. So you can have you have big drainage cannulas, which are often quite long, about 55 centimeters. Then you have return cannula, which can be really long if you're doing VV ECMO, because you might need to put them in femorally, or they can be short if going in the neck, or if you're going in the groin, you can have short cannula. So for VA ECMO, like I mentioned, we usually use like a 25 for the venous cannula and a 17 or 15 for the arterial cannula. It's important to know what the cannulae look like under echo, and that's what they look like. So this comes from a lovely publication from Kelly Victor, many years ago now. So the drainage cannula is the one that's labeled A, and that has a number of side holes on it, which you can see in the image B underneath. Whereas the return cannula has basically all the blood comes out of a series of jets at the front. So the return cannula have a series of little micro perforations just at the tip. Very important thing to remember is that because of the way these are constructed, you never see the true tip on echo. What you will see is the tip of the cannula is probably a couple of centimeters before the true tip. So just be wary of that, especially when you're guiding people to push things forward or pull things back on echo. So after you put your pipes in, you can confirm your position using either X-ray, fluoroscopy, or echocardiography. And how this is done will depend on where you are, how your institutional protocol works, and what you do. At Barts, we mostly use transthoracic echo. We will use TOE if we can get it, but it's just often because of speed. CT is easier and faster. Your subcostal views become your absolute friend when doing ECMO cannulation, and in particular the subcostal bicaval view that many of you may not be used to, but it's kind of a variant on the subcostal short axis view. You can only really get this if you do a true subcostal long axis, which is going through the liver, and by rotating to probably about 80-90 degrees, you'll then get a view where you can see both the IVC and the SVC, like you can see here in this picture. The other view that's really useful is what we call the double barrel view, which is putting the probe in a mid axillary line through the right side, usually just at the level of the nipple, and you'll get a view that looks like this, where you'll see both the IVC and the aorta, you see the IVC on top of the aorta through the liver. And this can be absolutely fantastic view, especially when you're doing ECPR and you need to cannulate in a hurry, because there might be a big thumper on the chest. You might not be able to see anything anywhere, and you can get a really, really nice view. And you can watch your wires and your pipes go up. So this is an example of just a standard subcostal IVC view with a wire in it. And so this is the kind of thing that you're looking to see. So if you're putting somebody on VA ECMO, you want to see, so for speed, especially what people do pre-hospital for ECPR, is they just look at the IVC, and what you want to see is one wire when people are feeding up what they think is the venous side, and no wire when people are feeding up what they think is the arterial side. In all barrel view, allows you to see both wires, and you can also do subcostal views where you can see both, and you can do TOE, or you get a bicable view and a view of the aorta, and you can see all. And once you've got your view, you're then going to stick your pipes up. So this is kind of, so here you can see a return cannula. You can see lots of little dots so that the return cannula is right in the right atrium. And if you look really, really close, you can actually see a drainage cannula just below that. So this patient's on VV ECMO. This is another example. So here's a drainage cannula, and this is just a single drainage cannula in a patient who's on a VA ECMO. This is what the TOE views look like. So this is a bicable view on TOE. There's the intraatrial septum there. That's the SVC over here. The IVC is down here, and you can see the pipe coming in from the IVC, and then it's trying to go through the right atrium, trying to go through the intraatrial septum into the left atrium. But thankfully the person's pulling it back, so they're behaving now. And as mentioned earlier, if you have somebody, so if you turn up to put somebody on VV ECMO, for instance, and they've got respiratory failure, but they've also got cardiac failure, putting them on isolated VV ECMO will not provide any support for the left side. So you might need to do what we call a hybrid configuration. That means putting in a third pipe, so putting in an arterial pipe, and then splicing your return from your ECMO circuit so that some of it goes down the artery, some of it goes down the vein, and that's called VVA ECMO. The reverse can also happen. So if you put somebody on VA ECMO, and in certain situations where the lungs suddenly become really, really crap, and the heart, and perhaps the heart's not so bad, you might need to provide some lung support as well, and that's called VAV ECMO. So then you put in a venous pipe, and then you splice the returns to give you an arterial and a venous return. Things start getting quite complicated when this happens. Little mention of something that you might read about, something on bicable cannulation. Some people call this the Avalon, the cannula, but then that's just because Avalon is just a brand name. And that's basically putting in a single cannula. It looks like basically a giant vascath into the SVC, or usually on the right side. And it'll go down and it'll go across the SVC into the IVC, and it will basically allow you to do both drainage and return through a single cannula. And it's quite useful because it allows people to walk around on ECMO. So if you ever see any videos of people walking around doing fashion shoots or playing basketball on ECMO, there's loads of these videos on YouTube. They usually have a bicable cannula. It's going out of fashion a bit because you can actually do all of this with just standard bifemoral configuration. So we're not, and these can be a bit of a pig because they move around and the positioning can be a bit of pain, but they're still popular in some centers. And this is what a bicable cannulation looks like. So you can see that there's basically a pipe going all the way up, or coming all the way down from the SVC into the IVC. Little note on femoral arterial cannulation, because this is really, really important. So when you're doing VA cannulation, you want to make sure that you puncture the common femoral artery. So you need to go above the bifurcation, but not too high as to be above the inguinal ligament. Otherwise, you potentially call the retroperitoneal hematoma. So ultrasound again becomes absolutely crucial for this. You want to make sure that you put the cannula in nicely, and you want to make sure that you see your wire. You puncture very cleanly. You want to make sure that you see your wire. You also need to give yourself enough space. So just to give you guys some ideas, so this is a look of what it can look like. This is a really nice video from the guys in Minnesota, and they are doing ECPR. So this is, you might have heard of these guys. So this is Dimitris Yiannopoulos and Jason Bartos, who are kind of probably the two world's experts at the moment at doing ECPR. So you can see the Lucas device ongoing. Dimitris already got into one vessel. So he's got his ultrasound, and this is in their big giant truck. So they use fluoroscopy rather than using echo. But he's already in one vessel. And then he's going to cannulate and get into the other vessel and just have a look. Yeah, there you go. That's it. That's how fast it is. Last thing to mention about VA ECMO is that you've stuck a big pipe, and this can also be true for impellers as well. You've got a big pipe sitting in the femoral artery in somebody who's potentially a vasculopath, and all the flows to the distal limb may become compromised. So you may need to put this thing in called a reperfusion cannula. We nickname it LEGMO because it's basically ECMO for the leg. And so you have to stick in a cannula pointing the opposite way, so pointing down into the superficial femoral artery, and then connect that to your circuit, and then let blood perfuse down that. So that's your cannulation. Once they're on ECMO, you need to monitor the patient, and there's lots of ways to monitor them. So you need to think about you need to think about lots of stuff. And in particular, you basically need to watch the heart every day until it recovers. And you may need to. So really, lots of people say if you're on VA ECMO, you basically have an echo every day. Some people do echoes twice a day, because the situation is constantly changing, and especially if they've got something that's recoverable, like like a bit of LV stunning or some myocarditis. That heart will change, and the loading conditions will change all the time, and that means the nature of your sport may need to change. But in particular, within the first few hours to days, the thing you want to really pay attention to is your aortic valve and your aortic valve opening, because that will particularly change the course of your ECMO support. One slightly nerdy thing I thought I'd mention is, and something that I'm kind of interested in, but I haven't had a chance to do enough of, and there's really no data on this, using transcranial Doppler to monitor your ECMO flows. So when you've got a heart that's terrible, your heart basically becomes non-pulsatile, and you start acting like you're on bypass. And when you put people on ECMO, they get a mean arterial pressure, and they get a non-pulsatile mean arterial pressure. What we don't know is whether or not we need to dial the ECMO support up or down to facilitate cerebral perfusion and minimize things like delirium. And it may be that transcranial Doppler and monitoring the MCA for mean velocities might be the thing to do. This is what it looks like. Okay, so talking about the aortic valve. The reason why the aortic valve opening is really, really important, because pictures like this basically make me very, very sad and very, very scared. This is a patient who's on ECMO and the aortic valve is not opening at all. Hopefully you guys can all see that. This is a terrible, terrible situation, because if that aortic valve does not open, eventually the LV will clot. And several things can happen. So one is the LV will clot. Second thing is the LV just will distend and will get bigger and bigger and bigger. And eventually that LV will then have all that blood shoot back up to the left atrium into the lungs. And this patient will basically just develop absolutely astounding refractory pulmonary edema that you cannot fix until you do something about that left ventricular. You do something about that aortic valve in the left ventricle, and this is what we call venting or decompression. So if you don't decompress an LV, this is what it looks like. So on the left, you just basically get all the smoke, and the LV just completely clots off. And the LV clots, it's game over. You can't fix that. You can't operate on that. They just die. And this is kind of an example of what that looks like. So this is a really, really nice case report. If people who don't read CASE, the case report journal from the American Society for Echocardiography, I highly recommend you read it. It's fantastic to have loads of case reports like this. And here you can see an absolutely terrifying image of an aortic root just full of clots, or full of, well, in this case, it probably wasn't full-on clots. It was spontaneous echo contrast. But yeah, this valve was not opening and looked like clot. And what they did was they put an impeller in. And an impeller, as mentioned earlier, it decompresses the left ventricle, right, and sucks all the blood out. And look, all that smoke's gone away. I think this, if I remember correctly, I think this patient actually survived. So there's lots of ways you can vent. So most people, the easiest vent, and the one that we use certainly most at Barts, is a balloon pump, and that's kind of really easy. You can stick that in the bedside. Doesn't cause relatively straightforward to do. You can use impellers. You can do an atrial septostomy, which is quite common in pediatrics. So you make a hole in the intra-atrial septum, and that will allow the LV to vent into the RV. And then your RV, don't worry about the RV because you've got a big drainage cannula that sucks all that blood out. So your RV is naturally decompressed. And then the last thing you can do is you can do what's called an apical vent. So you basically stick a pipe directly into the left ventricle through a mini stenotomy basically through the apex of the heart, and then connect that to your ECMO circuit. This is quite popular in some centers. I know the Alfred are big fans of that. This is what venting can look like. So this is a patient with an, hopefully you guys can all see this in the left atrium, and that's an atrial septostomy. And that's what the venting the heart. And just to show you how effective venting can be, this is a patient on ECMO with essentially a non-opening valve and a big distended left ventricle. And then you put an impeller in, and everything looks a little bit happier. The left ventricle is decompressed, and it's starting to move a little bit. So we can breathe, at least for the moment. But you can imagine once you start sticking all these devices in, you end up with groins that look like this, where there's just a bazillion pipes in, and there's no space to do anything. Another important thing to mention about, and the other reason why echo can be useful, is something called Harlequin syndrome. Now, this is uncommon, but it's worth knowing about. So you have a situation where you put somebody on ECMO, and their lungs are bad. So, but their heart's bad as well. So at the moment, what happens is you end up with a situation where the heart, basically the lungs are basically circulating deoxygenated blood because they don't really work, but you're bypassing them with your ECMO circuit. So you're giving the body oxygenated blood, and the heart's not pumping any of that deoxygenated blood, so you're fine. But what happens is, say the heart suddenly recovers, but the lungs are still bad. So the heart suddenly starts to pump out pretty decent amount of blood, but it's now pumping out a whole bunch of poorly oxygenated blood back up against that retrograde flow that you've got coming up your aorta. And so because ECMO is retrograde, you end up with a mixing zone, a zone where the oxygenated and deoxygenated blood mix, and the heart pumps forcefully enough that it pushes that mixing zone down the descending aorta to the point where you're now pumping a whole bunch of blue blood up into your top half, and you've got red blood perfusing your bottom half. So you're blue at the top and red at the bottom, and that's called Harlequin syndrome because of the Harlequins of old that had different colors on either side of their bodies. Some people call it North-South syndrome. I think that's actually the proper term for it. This is one of the situations in which you will have to put in, you may have to do VAV and go into hybrid configuration, because that's basically the heart telling you that they need lung support as well. There are a couple of other ways to try and manage this, but VAV is probably the most effective way to do it. So you need to think about the right heart as well, because you need to measure and you need to appreciate right ventricular dysfunction the whole time. So every day that you do your echo, you pay particular attention to the right heart, because if your right heart fails on ECMO or any form of mechanical support, it's pretty much, provided and you can't support it, it's pretty much game over. So you need to pay attention to all these things. You need to think about things like the pulmonary artery pulsatility index and look at your right ventricular function, both with 2D, or both with echo and with other parameters. You need to think about reasons why this happens. So, you need to think about preload, afterload, heart rate, and contractility. If you're at ECMO, you usually have drainage. If you've got an impeller, then you basically ignore the right ventricle and rely on its intrinsic function. So you need to think about other things that can cause that. But often it's pulmonary vascular resistance, so they get a pneumonia or something like that, and that's what makes it worse. Remember that the right heart has it's very, very pressure sensitive. So its Frank Starling curve is very different from the left heart. So the left heart will tolerate lots of pressure, and the right heart will not. So, with your 2D echo, you can tell a lot of information. So this is a nice TOE picture. So you can see here that the right heart's happy. Here you can see that the right heart's very unhappy. So the left heart squished. The interatrial septum is bowing over to the left. The right atrium is ginormous. The tricuspid valve is barely opening. And the right ventricle fractional area change is poor. So this is a terrible struggling right heart. And you can see that with color. So this patient's got torrential TR, and that's the reason why the right heart's very unhappy. So if they've got right heart dysfunction, you can try and manage the cause, do things like lung protective ventilation, or you may have to change your configuration and think about right heart support. Again, usually not a problem on VA ECMO, because VA ECMO is very, very effective right heart support. But if you've got a univentricular support like an impeller or a balloon, they might need to think about that. If you need right heart percutaneous support, you have to think about an impeller, or you've got something called a Protect Duo, which is basically an RVPA cannula. That's basically just kind of like mini ECMO, but just for the right heart. Last bit's about weaning. So weaning from ECMO was a bit weird. There are these papers and classical papers that describe all these parameters that are associated with successful weaning. So that's kind of what we look for. But really what you want to do is, first of all, you want to wait until, so the heart should get better. And there should be lots of things that tell you that the heart's getting better. In that, the patient has, the patient starts ejecting, they've got a pulsatile waveform on their arterial line, the perfusion's better. And the insults, so has been fixed. So they got cardiogenic shock from myocarditis, you've given them some steroids, and the heart's looking better, or they've had an AMI and you've stented the lesion, the heart's looking better. There are all these parameters that are associated with successful weaning, which are usually like an ejection fraction, a VTI. However, these things are a bit complicated because nobody specifies whether you need to be on inotropes or not for them to not be weaned. Because lots of these patients will end up still on a degree of inotropy in order to keep the aortic valve opening. So, and then for VV, it doesn't really matter, because VV you wean basically by lung recovery, just by turning the amount of oxygen that you supply the ECMO down. But so for VA ECMO, it's a bit more complicated. But really what you want to do, if you think the patient's ready to come off ECMO, you want to look at the heart and you want to turn the ECMO down. And then as you turn the ECMO down, what you see is the heart, because ECMO actually reduces your ventricular function, because it's increasing your systemic vascular resistance and you're increasing the amount of resistance your heart pumps against. As you turn the ECMO flows down, your heart should get better and your cardiac output should actually go up. And they should do so without compromising anything. So without compromising right heart function and without things like MR or the MR getting worse. And that's really what you're looking for in a weaning trial. Everything else, all the numbers, blah, 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 they're all just numbers. And I'll kind of show you what that looks like in a real patient. So here's a patient with with significant LV dysfunction. So you can see that this classical appearance of myocarditis, the LV is kind of thick and speckled. You've got small pericardial effusion. There's a balloon pump in the descending aorta. Hopefully you guys can see that all here. But this is much better than, believe me when I say that this is about a bazillion times better than it looked when we put this patient on ECMO. When we put the patient on ECMO, the heart was basically standstill. The heart's recovering. This is in short axis. The ejection fraction is probably about 30%. It's not looking too bad. Unapical 4-chamber, again, the heart's, it's not perfect, but it's not the worst than it's much better than it has been. And many of you eagle-eyed people might spot this. So there's a little clots associated with the ECMO drainage cannula, and it's close to the intraatrial septum. So this is something for us to be aware of. So as we start turning, so here, we start writing the ECMO flows down, and this patient is on 2.6 liters per minute of peripheral VA ECMO flow. And then as you turn the flows down, hopefully you guys can appreciate that the myocardium is now starting to contract a little bit more. So now that ejection fraction is now looking a little bit more like 35. And that's the apical view starting to look a bit better. Then we'll turn it down even more. And then the heart's starting to pick up. And the VCI on 2.6 liters is 15. By the time you get to 2 liters of flow, the heart's actually looking more, it's starting to approach the dizzy heights of 35, 40. And that VCI has gone up to 16.7. So that's kind of what you want to see. In terms of data to support the use of mechanical support in cardiogenic shock, at the moment, there really isn't any papers to support the use of mechanical support devices aside from danger shock and impellers. All the ECMO data so far is not great. So there were 2 big papers, ECMO CS and ECLS shock, that showed no advantage of putting people on ECMO and cardiogenic shock, whether they were Sky C or Sky D. That puts into question a lot of stuff that we do. But the challenge here is that the trials are difficult to do because they're not really blinded, and it's a bit of a mess, and you get people wrong times, and there's lots of stuff going through the news. Nonetheless, going through the research world. Nonetheless, again, NICE have actually provisionally approved the use of ECMO for both cardiogenic shock and for general cardiogenic shock and post cardiotomy and for ECPR. So again, this is coming, whether we like it or not. A little bit of stuff about weaning. So this is a great paper from a Korean group that looked at the successful predictors of weaning for mechanical. They looked at lots of parameters. So the paper that everybody quotes standardly for weaning is a paper by Nadia Saoui from France. But this Korean paper was bigger. And the 3 big things that they showed was effective left, that correlated with successful weaning was left heart decompression, improvement in lateral E prime. So basically your heart picks up as you get better, and an improvement in your tricuspid S prime. So your right heart's really important. Just to give you an example of how complex it can be. So this is, I hope Richard's not on the call. Richard, I love you to bits, but your weaning guidelines are too complex. These are his weaning guidelines from King's. So they have a 13-page guideline on how to wean people from VA ECMO. In Barts, we have a single data sheet that looks like this, so a single piece of paper. We copy and paste this into our notes. That's what we did. Hopefully you guys recognize this. This is Bob Bartlett, the father of ECMO who passed away a few weeks ago with a nice dog on ECMO. This is just my way of giving some acknowledgments to all the people who shared all their pictures. And that brings me to the end. So you can't do ECLS or and mechanical support without echo, really. It's very much kind of the fusion of critical care and echo. So if you're serious about critical care echo, you really need to learn this. If you want to be a leader in critical care echo, you need to learn this. How you learn this, I mean, it's going to come anyway. It's happening whether we like it or not because of all the NICE approvals. So if things go ahead and if NICE go ahead with a payment package for all of these things, there will be a mini explosion certainly in impeller usage from our cardiologists. So you need to find out from your cardiologists who are going to start doing this. And there may be more and more ECPR starting to happen as more and more pre-hospital crews start to engage with it. So in London, we're currently doing pre-hospital ECPR, and lots of other pre-hospital services expressed an interest in doing this. So you may end up with just an ECMO patient dumped in your ICU, and you need to know how to manage these patients. A little bit of reference for everyone, and I think that is the end, and I'm happy to take questions now.